Thank you for those kind remarks, Harvey. I'm going to try and, can you hear me? Is this working? Good. So that I can see and point to some things that come up on the slides. So Harvey actually has done a brilliant job, as usual, of summarizing my talk in 3 minutes. But now you're going to have to hear it on a longer episode for about 20 or 30 minutes. So to put preventive medicine in perspective, we have the god Aesculapius, who had 2 daughters, Hygeia and Panacea. And Hygeia was the goddess of the promotion of health. Panacea was for the cure of disease. And we can see this great dichotomy, which really isn't a dichotomy when you think about it, in modern medicine today. This is a photo I took in Melbourne a few years ago when somebody was showing me their grandfather's medical clinic, and he had these beautiful, from the 1920s, in Melbourne, Australia, etched windows. Important, and we all are involved in prevention. So those who are working in the emergency room are doing tertiary prevention. Somebody comes in with chest pain, and they jump on them, they give them clot busters, they do cardioversion. That's prevention. They're preventing a death. But if you go back up the train track, you can do something before you get to that stage, and we could call this secondary prevention. They're getting sclerosis, but they haven't yet had a heart attack, so if you take aspirins, if you use antiarrhythmics, you're preventing that myocardial infarction down here. Secondary prevention, or as most of us would like to see more frequently, primary prevention. Stop the arteriosclerosis from the very beginning, and that's, of course, eating a proper diet, getting exercise, not smoking, and keeping an appropriate weight. The problem is prevention is hard to do. Usually what we're doing is taking away something that people like: red meat, tobacco, sex, breathing, asking people to do things they don't like. Exercise. It often costs a lot of money, and it becomes a political football. And is underappreciated, because when prevention is successful, nothing happens. Now, there was once a disease that was common around the world, smallpox, and my predecessor as Dean of the Hopkins School of Public Health, D.A. Henderson, ran the program that eradicated smallpox from the world. And what he frequently reminisced on is that nobody is grateful that they haven't died of smallpox. So when we are successful at prevention, nothing happens, so nobody is appreciative. And so money doesn't go into prevention the same way it'll go into those sophisticated instruments that have already been alluded to. So now the vitamin A story, a little bit expanded. This is E.V. McCullum. E.V. McCullum was the first professor of biochemistry at the Hopkins School of Public Health, and he also discovered vitamin A. So we have a long history at Hopkins with vitamin A, and this is an article from 1913. This is a photo from the field simply to prove that I was once younger, I once had hair, and that I actually lived with my family, 2 members of whom are here today, in Indonesia, where I went, as Professor Feinberg has indicated, to study as an ophthalmologist, study how large was the problem of vitamin A deficiency as a cause of eye disease in young children. Why did some children get it while others didn't get it, and what could we do to both better treat it and prevent it? And this is a child at a slit lamp where I'm examining the eye. So a little something about the eye disease. So when I became involved in this, what we called mild vitamin A deficiency was all related to symptoms in the eye. And the first symptom that you develop is night blindness. So this is a cartoon to suggest that a child who is not vitamin A deficient, or a pregnant mother for that matter, because it's also very common amongst women during their 3rd trimester of pregnancy in these poor populations, that at night someone who's not vitamin A deficient, because of a candle or moonlight, will be able to see their food, walk around the village at night. But a child who is night blind is absolutely blind at night. They can only see during the daytime. That occurs because vitamin A is necessary to make the visual pigment in the back of the eye that allows you to see under low levels of illumination. And you've all had this experience. when you're outside on a sunny day and come into a dark theater for the first moment or two, you cannot see anything. You can't find your seats, and over the next minute, minute and a half, your vision comes, you can see the seats, and you can sit down. Well, you are dark adapting. Well, a child who doesn't have enough vitamin A cannot dark adapt, and it stays black until there's bright sunlight. The next thing that occurs to the eye, which we also called mild vitamin A deficiency, is called a Bito's spot, and is a little foamy patch on the side of the eye. The trouble is all those are quickly reversible, but then you can get this thing called keratomalacia, where within moments the entire cornea can melt away and that eye is lost. So at the end of our first year and a half, 2 years of studies in Indonesia, we were able to summarize some of the relationships between vitamin A status and blindness. Is that there were 63,000 new cases of corneal ulceration, therefore blindness, in Indonesian children every year. That there were 500,000 new cases of corneal ulceration each year in Asia alone, that we estimated from our incidence and prevalence data, and that we had already shown that 1 2-cent capsule of vitamin A twice a year could prevent all of this. And so we went off to ministers of health and told them this is a big problem. For 2 cents you can prevent children not only from getting night blindness, but in fact going permanently blind. And was that enough of a problem? The answer was no. So the economics comes into this, and it's a value issue. And what ministers of health would tell me, perhaps not irrationally, that, Al, we have $1 per year to spend per child. Now, we're using that on vaccines, we're using that on oral rehydration therapy. Should we take that away from child survival just to prevent blindness as badly as we feel about the blindness? So that was their argument. Fortunately, we then went on to make another discovery that wrapped the whole thing together. So this is a child who would have severe vitamin A deficiency. That eye is blind. This eye would go blind within the next few days, but we give this child vitamin A, and that eye will be saved. But this is what severe vitamin A deficiency looks like. This child obviously is severely malnourished, protein energy malnutrition, kwashiorkor, diarrhea, pneumonia. In the villages, we estimated that these children who go blind, 95% of them will die within a year. In the hospital, only 25% will survive in any case, because they're very sick children. So that it was no surprise that severe vitamin A deficiency was associated with high mortality in children. What was interesting is represented by this child. So this child is well-nourished, doesn't have pneumonia, doesn't have diarrhea. He came to the clinic because he had night blindness, this early vitamin A deficiency. And this is where the news story begins. So the news story that has already been referred to is we had undertaken a study, an observational study, to better understand why some children developed vitamin A deficiency and the children next door did not. And so what we did was we followed 4,000 children and examined them at baseline, 3 months later, 3 months later, and so forth and so on, for 7 examinations over the course of 18 months. And the idea was to say what was different between children who developed night blindness or Bito spots, what we called early mild vitamin A deficiency, and those who didn't. And that's when this unusual observation occurred, that the children who at the beginning of an interval already had night blindness and Bito spots were much less likely to show up 3 months later than the children who started off the interval with normal-looking eyes and therefore with a better vitamin A status. Remember, we thought then we were simply comparing children with very mild vitamin A deficiency, because if it was more severe than this, we took them to the hospital and treated them, versus children who had only slightly better vitamin A status. So we turned this on its head and we said, okay, if a child has night blindness and Bito spots at this observation, what's their risk of dying here compared with children whose eyes look perfectly normal? What was their risk of dying? And this is what it looked like. So this was the mortality rate of children who at each interval started with normal-looking eyes. These were not normal children. All of them were vitamin A deficient to some degree, but there wasn't sufficient to cause these mild eye signs. The children with night blindness were dying at 3 times the rate of the children with normal-looking eyes. The children with beto spots were dying at 6 times the rate, and the children with the two together were dying at 9 times the rate, roughly. So this one was very surprising, but the kind of data that an epidemiologist absolutely loves. Because not only was there an association between vitamin A status and death, but it had this nice dose-response relationship. The more vitamin A deficient, the greater your likelihood of dying. Now, this didn't prove that vitamin A status was the cause of death. I mean, it could have been something else that tracked along with vitamin A deficiency that we didn't measure. So even though we cut this up everywhere we could, we always ended up with this dose-response relationship. And there's only one way to prove that it was vitamin A status alone, and that was to do a simple-minded, classic, randomized trial where you take 25,000 kids, and half of them get vitamin A twice a year, 1 dose, and the other half don't, and then see what the mortality rate in the 2 groups are, because that way we've only changed one variable, their vitamin A status. Whatever else is different is randomly distributed between the 2 groups. So anyway, this was the result. This was the paper, and there was one in the Lancet as well. This was in the Transactions Ophthalmological Society of mortality associated with untreated xerophthalmia. So this is the first of our randomized trials. We randomized 450 villages, 22,000 children. Just to give you a sense of the magnitude of these studies, these are not the study participants. These are the field workers who are taking about 1,000 field workers who are monitoring what's happening to the children over the course of the year. And this is a cumulative mortality, which shows that this was the first dose was given over here, the next dose was given over here, and as you can see, the control group died at a much higher rate over the 1-year follow-up than did the vitamin A group. So this was a paper that reported that study, published in the Lancet, and it received an enormous number of letters to the editor, not one of which was supportive. As they said, no, this is ridiculous, 4 cents worth of vitamin A can't reduce child mortality by 1/3. That's absolutely absurd. But interestingly, nobody else was interested in either going out and proving we were wrong or going out and proving we were right, so we were forced to continue to do this over and over again until finally we convinced people. And we did break Fett's law of the lab, which is to never replicate a successful experiment. So this is the next trial we did in Nepal. And here we gave 1 dose every 4 months just to vary on the theme. And as you can see, with each 4-month interval, the blue bar were the placebo villages, the yellow bar is the vitamin A villages, and in every interval, the children who villages which received placebo died at a much higher rate, and we had to stop the study early because we reached overwhelming statistical significance. And then again, just for fun, because I like doing these things, instead of just stopping the study, we said, well, now let's, now that we, in this population, be unethical to continue it, let's just continue it, but for the next 2 rounds, let's give the placebo recipients vitamin A instead of placebo, and you can see that the placebo mortality group comes right down to the same thing as the vitamin A. So it's a nice little frosting on the cake, demonstrating that no matter how you look at it, this is an effective intervention. So by 1992, there were 8 studies done in 3 countries in Asia and 2 in Nepal. Almost all of them, it was rather striking to me, except for 2, there were very similar results across the board. These 2, I can tell you, were very poorly done studies, and we said so before they were ever done. The way they were designed, the way they were carried out, we said that these will not show a difference because they will not be effectively separating the 2 groups and giving them what they were assigned to get. I won't get into that. And that's why the 23% is actually wrong, because they include these 2 poorly done trials, but nonetheless, everybody likes meta-analyses these days, so you have to live with them. But I took out one of those. I took out one of the African studies, and these are all now Asia. And if you do the Asia meta-analysis, putting all the studies together, including one of those two that had very little impact, you get about a 34% reduction in child mortality, which is pretty much the same as we got in that very first study in Aceh province in Indonesia. Now the question then was, well, what are these children dying from? What is it about vitamin A status that causes them to die? And it's a hard thing to tease out, because remember, these are large numbers of children, rural areas. They don't die in the hospital. They sort of die when they die at a home, and then a field worker lets a physician know, and the physician comes, can't examine the child's already gone, but asks the parent, and you try to tease out what the cause of death was. It's called a verbal autopsy, and it's approximately right, and it's much more right when it's something that is obvious to the parent that the child has a disease. So measles is obvious to a parent because of the rash. Diarrhea is obvious to the parent. Respiratory disease is much more difficult, so we're not too sure, but there's no obvious impact. But here in diarrhea and measles is about a 50% reduction in mortality from diarrhea and measles. And this is the prevention studies. Here are 4 studies in which children were given vitamin A once every 6 months, and then we went back to see what happened. And as a cause of death from measles, roughly a 50% reduction in measles mortality rates. So then something, again, unplanned happened. I got a call from Sir John Wilson, the Royal Commonwealth Society for the Blind. He said, Al, we're having a big problem in Africa. There are lots of children who are going blind from measles. Could you come and look at what the issue is and maybe give us some ideas? So I went off to visit a couple of countries in Africa, and nothing is quite as exuberant as young African school children or quite as depressing as blind children. And many of these children who are blind in the school that had both sighted and non-sighted children was that they went blind following a measles episode. And this was one of their teachers who had gone blind at the age of 5 following measles. So now we're in something interesting. There's something going on with measles that we don't see in Asia, and I cannot explain what the difference is. But the first study we did in a small mission hospital in Mvumi, the center of Tanzania, with a colleague, an English ophthalmologist who was running the hospital, was to look at the causes of corneal ulcers and blindness following measles. Children admitted to the hospital with severe measles, and at least half of them were clearly due to vitamin A deficiency. And in fact, all the cases of blindness following measles were due to vitamin A deficiency. So then we asked the obvious question, well, if a lot of the blindness is due to vitamin A deficiency, then maybe the high mortality rate associated with measles in Africa is also due to vitamin A deficiency, even though they don't have a lot of night blindness and Beto spots for some reason. And so what we did was a clinical trial of children with severe measles who came to the hospital, were hospitalized, and we randomized them into 2 groups. One group received routine therapy. The other group received 1 dose of vitamin A on 2 successive days. So this is treatment in children who are near death with severe measles. And what we received here is the mortality rate amongst those who got standard treatment was 13%. And again, vitamin A treatment reduced the case fatality rates by 50%. So this is sort of as good as medical intervention research gets. If you improve vitamin A status, over the next 6 months, children are less likely to die from measles by 50%. If you treat a child with severe measles, they're less likely to die over the next 5 days, because these are kids with severe measles and near death, by 50%. So it's a nice story that sort of came together. Now, there's a reason why what we do is called research. After we published this, fortunately, we discovered it. Nobody else discovered it. Somebody had done exactly this trial, pretty much exactly, about 50 years earlier. So this is in London, England. In 1930 was when the trial was done, published in 1932. Now, they didn't have pure vitamin A then. But what they did have was cod liver oil, which contains vitamin A. It's a very good source of vitamin A. And he took these children who were being hospitalized in London for severe measles in 1930 and randomized them to either receive cod liver oil or standard therapy. And he got also roughly a 50% reduction in mortality. So this is a little embarrassing. That's why I never write a paper that says this is the first time that it has been shown, because guaranteed someone will find a paper that showed it before you did. The other thing that made this a little embarrassing is this was published in the British Medical Journal. Our article was published in the British Medical Journal. Of all the journals we could have published it, we happened to publish it in the British Medical Journal. So by 1990, we had this study from England. 1932 it was published. Our study from Tanzania, and then there was another study that followed our protocol carried out in South Africa. Again, roughly 50% reduction in case fatality rate amongst children with severe measles. That led WHO and UNICEF to recommend that all children with measles receive vitamin A as prophylaxis, a recommendation that the American Academy of Pediatrics has agreed to. So by 1992, I was getting tired of doing these studies and thought they were becoming unethical. And so I called together everybody who was doing these studies and a few other experts. We went to the Rockefeller Study Center in Bellagio, which is hard to disagree, of good food, good wine, beautiful scenery. And we went through all the data to see if we could come to an agreement on whether vitamin A, in fact, made an important difference in child's lives. And at the end of a week of reviewing all the data and discussing it and arguing about it, everybody agreed that by improving vitamin A status, we would reduce all-cause mortality by 1/3, specifically reduces measles and diarrhea mortality, and prompt treatment cuts measles case fatality in half. I had everybody sign this summary in blood and then go back and ask them to publish their feelings about this meeting in their own local medical journals. So over the next few months, there were articles in many medical journals all coming to the same conclusion, and that allowed the whole field as a programmatic initiative to move forward. So what's going on? How did we change this paradigm? So in this cartoon, eventually, this is when vitamin A status declines, we used to be focused entirely on the ocular signs. Now we know that as it declines, the first changes are not ocular, not the eye. The first changes that happen is an increase in the severity of infections, increase in mortality, anemia, and decreased growth. And it's only later that you, in fact, get night blindness and zero. So night blindness may be a mild eye condition, but it is not mild vitamin A deficiency. It's already severe vitamin A deficiency as far as the systemic complications are concerned. Vitamin A deficiency is common throughout the developing world. We estimate roughly 200 million children have physiologic changes due to vitamin A deficiency, that about 3 million children and 3 million pregnant women develop some form of eye disease, night blindness, beat spots, every year, and about 500,000, primarily children, will go blind from vitamin A deficiency a year, and 1 to 2 million people will die each year vitamin A deficiency unless you have intervention programs. UNICEF wonderfully does have such a program. It supports it around the world. There are 70 countries around the world that report giving vitamin A, these large dose supplements, to 80% of the children. At least that's what they report. And so UNICEF estimates that there are perhaps 500,000 children who are not dying each year who otherwise would die, although if we could improve coverage rates, something that Esther is very interested in, then perhaps we will actually be able to prevent all of these deaths. So to summarize, we began with data, but not everybody interpreted that data the same way, so we had to interpret the data, and there are lots of ways to interpret data, and then we had to work hard to get a scientific consensus, and once you get a scientific consensus, it doesn't prove a lot in terms of changing to policy, because then you have to deal with competing priorities. Remember whether you would give vitamin A to prevent blindness alone. Now they'll give vitamin A because it prevents blindness and prevents childhood deaths. You have politics, you have media attention, you have special interest groups. So going from science to policy to programs is a stepwise process, each step of which has its own challenges. Now, I am always concerned putting a slide up that deals with economics, and particularly today with Esther in the audience and about to speak. And I always say, don't take these numbers literally. They're just an order of magnitude. But some economists, not me, looked at cost effectiveness of vitamin A intervention, and this is the dollars, roughly the dollars that need to be spent for each death averted. And so they estimated that roughly $23 need to be spent in vitamin A treatment prevention programs, whereas bed nets are $200 and oral rehydration therapy $4,000 for every death averted. And you don't see too many analyses like this. There is this thing called the Copenhagen Consensus, where a group of economists get together. This one, I think, started in 2004, assessing where one could make the best investments in the developing world in order to improve development. And they have repeatedly each year, this is 2012, hunger and malnutrition tops the list. And here you have it, number one, bundled micronutrient interventions to fight hunger and improve education. And so the final question is, are we making a difference? And I think we are. Thanks very much.